thank you, doctor, for joining us today. And let's start off with prostate cancer. And how bad is prostate cancer, and what age do you need to start seeing checkups and things like that?
So, like all cancers, there are different grades, and there's also different stages. So, when we look at grade, we're looking at essentially under the microscope, so a biopsy of prostate cancer. Looking at the histology of prostate cancer, sometimes you get a sense of whether it's going to be an aggressive prostate cancer or a lower grade prostate cancer. And if it is a lower grade prostate cancer, then those prostate cancers in some instances may not even need to be treated, particularly if somebody is elderly. So for example, if you have a 90-year-old man who's diagnosed with a high PSA and then promptly has a biopsy, and the biopsy shows a Gleason 6 tumor, you have to take the prostate cancer in the context of the patient, this 90-year-old man who's got heart disease and diabetes. And in that instance, you may decide that it's not appropriate to treat that patient, or you wouldn't worry about the diagnosis of prostate cancer. Whereas if you have a higher grade tumor in a younger patient, so for example, we use Gleason, one of the things that we tend to use is grade groups and Gleason, which are certain things that the pathologist will report when they look at a prostate cancer to give us a sense about the severity or the biology of the prostate cancer based on what they're seeing under the microscope. So if you've got a younger patient who has got a higher grade tumor or a grade group that is higher, and those cancers tend to behave more aggressively, then you would be more prone to thinking that actually for this particular patient, a more aggressive approach is warranted, and that may be a prostatectomy, so removing the prostate itself, or radiating the prostate itself.
Okay. Now, talking about that, early detection in cancers is definitely very important. And what about people who develop later stage of prostate cancer? What is their outlook?
So if a patient has got metastatic prostate cancer, and what I mean by metastatic prostate cancer is prostate cancer that has spread outside of the confines of the prostate. So it can be prostate cancer that has gone to lymph nodes beyond the pelvis, or it can be prostate cancer that has gone to bones, predominantly in the context of metastatic disease, and occasionally lung and liver, but that's very rare. So the prognosis for patients with metastatic disease is that it is not a curable treatment at the moment. Although we have made quite significant advances in treatments for patients with prostate cancer and certainly continue to improve survival for these patients, unfortunately it remains a disease that is lethal.
Okay. Now let's move on into symptoms. What are the type of symptoms that people can look out for?
I think in the context, architecturally you have to just remember where the prostate sits. So the prostate sits behind the bladder and in front of the rectum. And so it's sort of sandwiched between these two organs. And in fact, the urethra that drains urine from the bladder itself travels through the prostate to get out. And so you could imagine that some of the symptoms that a man might experience as the prostate gets larger could be things like urinary urgency, so urinary symptoms largely. So it could be urgency, needing to run off to the toilet lots of times. It could be hesitancy where the stream has become very slow, producing small amounts of urine intermittently. It could be nocturia, meaning that the patient is getting up at night a lot of times. And so these are symptoms to suggest that something's wrong with the prostate. There may be some pressure on the ureter causing a bit of irritation, and that should prompt someone to go and have their prostate checked. It doesn't necessarily mean they have prostate cancer. One of the most common causes of some of these symptoms is what we call benign prostatic hypertrophy, meaning the prostate is getting bigger as men are getting older, and so there's this sort of pushing in on the ureter effect that occurs. But it should prompt people to get a checkup if something has changed in their urinary symptoms.
Okay. Now, when you said for people to go to check up, what actually happens in the diagnosis? What tests are being done, and then how do people diagnose?
Yeah, so the patient would, turn up to probably the GP or a specialist, but it might be a GP initially that refers the patient to a specialist. The GP might do a blood test, and prostate-specific antigen is one of the most common blood tests that is done. And if it's elevated above the normal range consistently and is rising, that is worrying. That suggests that there's something making the PSA, and often it's the cancer that's making the PSA. So a GP might do a PSA blood test. A good GP would also do a rectal examination at the same time, I hope, to examine the prostate, and you can get a sense with your finger on the rectal examination whether it feels normal or whether it's hard or there's a mass in that area. And so that should be the first examination. But if there's something that is abnormal, then essentially the patient will require more imaging of the prostate. People increasingly do MRIs of the prostate, and the MRI of the prostate can give you a good sense of what the prostate looks like, and if there is an area within the prostate itself that looks abnormal. And that's also helpful in terms of biopsy, so that you direct the needle in a more specific way to improve the yield of the biopsy. Because if you do it in a blinded way, perhaps that's not as accurate. It still is accurate, but it's maybe more accurate if you have imaging to guide where you position the needle to get the biopsy results.
Okay.